Hello, everyone. It is a great pleasure to welcome you again to another episode of Heart to Heart Conversations. This series is intended to provide answers to often asked questions and hot topics in interventional cardiology. And today I am more than happy to be joined by Simone Biscaglia from the Ferrara University in Italy, who is an experienced user of angiography-derived coronary physiology, and him and his team have produced a lot of data in this field. We are looking forward to discussing the question whether this technology will change our practice in the lab. Before continuing, I would like to remind you that you can watch us across different platforms, from PCR Online, where you can ask questions, to LinkedIn, Facebook, YouTube, and X. We'll welcome all of your comments, and we hope that we will provide you with an overview of this important topic. Simone, welcome. It is great to have you.
Thank you, Dejan. It's a pleasure to be with you today.
Thank you very much. I would like to start our discussion by posing a question which has been on my mind for quite some time. And that is, what is to you the promise of the angiography-derived coronary physiology? What is it that it will provide us with that we do not have at the moment? We know that the FFR is well established. We do know from the everyday use of it, and especially following the results of the RIPCORD 2 trial that showed us that there is certain percentage of patients with complications with the wire-based approach. In the RIPCORD 2 trial, it was close to 2%. And we know that in some patients, we may have doubts about which technology to apply. So what to you is the promise of angiography-derived coronary physiology?
Well, I think that the promise of the technology is to increase the penetration of physiology in the cath lab. So by reconstructing physiology based on angiography, the basic idea is to increase the number of patients in whom we are able to estimate and to measure physiology, and also to increase the penetration of physiology, especially in settings where in clinical practice it could be different, to open the wire, to induce hyperemia. So, for example, acute patient or non-culprit lesion stratification. So, again, the basic idea is to increase the penetration of physiology across different clinical and practical points.
So you think in the cath lab of the future, we will be able, by just doing the coronary angio at any point of the procedure, whether as a diagnostic or throughout the procedure or at the end of the procedure, we will be able to immediately see the coronary physiology findings for that particular angiogram?
Yeah, I think that's exactly the direction we are heading to. So the idea is that in a few years, most of the angiographic systems will have the integration of physiology and of reconstruction of physiology in the angiogram. So what we will have is basically an automatic estimation of physiology based on the angiography in most of the cases and most of the steps of the procedure. As, for example, now you may use an enhanced stent visualization system in some points of the procedure in order to help you guiding or deciding whether to post-dilate or not a stent. The idea could be the same for physiology, either for the stratification or the optimization of the PCI.
So if the promise is to make physiology ubiquitous, to make it available in every cath lab at all times throughout the procedure, then we have three remaining segments which I would like to cover with you. And that is, if you could explain to us the principle of angiography-derived coronary physiology, because to many of our colleagues, this is not clear. Then we will talk about the evidence and the already existing practice applications from your experience, but also from some of the evidence that you and your group generated. So let us start with the principle. So can you tell us more about the principle of angiography-derived physiology? How does it work?
So we always start from the angiography, and this is also a very practical point because a good angiography is the first step towards the possibility of having a good reconstruction of physiology in the vessel. So across different technologies, we may need 1, 2, or 3 different projection per vessel. So you have to know which are the projection for each vessel. For example, for the LAD, you may have a cranial view and the right cranial, and they have to be angulated, so at least 25 degrees of angulation between one and the second projection in case you need two. And then once you have the angiography of the coronary that you want to evaluate, then what the system does is to perform first a three-dimensional reconstruction of the vessel, so of the anatomy of the vessel. And then on top of the three-dimensional reconstruction, and again, this is an important point because the reconstruction is based on the angiography, so the quality of the angiography is of paramount importance for the reconstruction of the flow. Then what happens is that the system estimates the flow within the three-dimensional reconstruction of the vessel. Each system has its own way to do it, and what the output of this of this analysis is actually a longitudinal vessel analysis. So the estimation of the value of FFR across the vessel, but at the same time, the reconstruction of the flow across the different parts of the vessel. So an automatic pullback of the physiology of the vessel, and then based on the interpretation of the value that has the same cutoff of FFR, so 0.80 in terms of indicating PCI. On top of that, what you have is also the information about the pattern of coronary artery disease and the presence of focal gradient or diffuse disease across the vessel.
Thank you for that. So I would like to reiterate, basically, based on what you just said, when you do angiography-derived estimation of FFR, you automatically generate an image that is based on angiographic image, and this new image tells you basically, or gives you, the longitudinal vessel analysis in terms of physiology. It gives you an estimation of the pressure gradient across the coronary artery tree, basically across the vessel of interest. This means that it is more than what the FFR value will give you unless you perform a pullback of a wire. So what the angio-derived methods give you is similar to a pullback of a wire-based technology, correct?
Yeah, exactly. This is automatically generated. Once you perform the analysis, you will always end up with the value, that is the FFR value estimated, and a pullback. So the interpretation of the pattern of disease across the vessel that you are interrogating. So as you correctly said, in order to do that with the wire, you should perform your FFR or resting index or whatever, and then perform a pullback in order to have the same kind of information with the wire. Yes.
Okay, great. So the longitudinal vessel analysis, the pattern of the disease, whether it's focal or diffuse, will help you plan the procedure and guide the procedure further. Now, to a more technical question, what variables that we generate are the ones which help us reconstruct and make this physiology or gradient at the end of the day? So we give contrast into the coronary tree. We generate a two-dimensional image which can be reconstructed into a three-dimensional image. We have aortic pressure as another variable which is measured. Everything else is either an assumption or a simulation. Can you tell us more? What does it mean to simulate fluid dynamics? And what is it that we assume up front so that help us generate the numbers that we get? QFR of 0.66, for example, for a lesion in mid-distal LAD. What are the variables that we really measure, and what variables are assumed and how?
Yeah. So as you said, the first point is when you perform the angiography, you have to, for example, to start with nitro, because that is another very important point in order to have a good angiography and not to have the underestimation of the anatomy, because again, what you measure is the three-dimensional reconstruction of the vessel based on the angiography. So this is the first point. And in order to do that, as we said before, you may need 1, 2, or 3 different projections. And obviously, if you perform, the more projections you perform, the more accurate, I would say, would be the analysis in terms of three-dimensional reconstruction of the vessel. But then the other systems, in order to improve the reconstruction, reducing the number of projections, what they do is to estimate, for example, the impact of the side branches. So again, that is an imputation for some technologies and is measured from some other technologies. So the impact of the flow across the vessel can be measured also by estimating or measuring the impact of the side branches. That is another point. And then what you have also is that you make some of the technologies correct for the flow, for the actual flow of the vessel. That is basically, for example, for QFR is the Timi frame count. So the flow that we are all aware of when we perform coronary anterior angiography. And basically, it is, I would say, a correction. It could change a little bit the value in terms of increasing or reducing the QFR or the angio-derived FFR value, depending on the flow at the level of the vessel. So, as you said, another parameter that can be measured in some of the technologies, not all of them, is the mean aortic pressure. In general, what you don't need is to induce hyperemia. So all these measurements are performed on a baseline angio. Obviously, you have to perform nitro before the angiography, but not to induce hyperemia, just to have the correct visualization of the coronary tree.
So, if I understood correctly, the maximum flow is assumed and the resistance is assumed as well. So these are the variables we don't really measure. These are assumed, and then the computer simulation will give us the output. The computer simulation of the flow, of the maximum flow, will then give us the output like QFR, MUFR, and other technologies. So the numbers we get are based on those assumptions together with the reconstruction of the image that we provide with angiography.
Yes, because this was the very first part of the studies on angio-derived FFR. So basically, to understand whether it was needed to induce hyperemia in order to estimate FFR by angiography. And the results of those studies were that it was not needed. So it was as accurate as in the three-dimensional reconstruction during hyperemia, the one performed without hyperemia. So obviously, then we started to use the reconstruction without hyperemia.
Great. So what you taught us now is that we can derive approximations of the FFR value from angiographic images without hyperemia. And most calculations are done by the fluid dynamics simulation with the assumption of the maximal flow and the resistance and all other things which go into mathematical modules. But for the practical purposes, we do not need hyperemia. We need high-quality angiographic images. And what we get is not only the value of the most distal part, but we get the longitudinal analysis, and we can find out the pattern of the disease. Now, when we learn this from you, the next question is, what sort of evidence we have? And when we think about the first line of evidence, those were, I think, correlation studies between different angiography-derived technologies and the wire-based FFR, which is considered to be the gold standard. And most of those technologies showed pretty good correlation with the wire-based FFR. What is your comment on these studies? Do the technologies differ between themselves, among themselves, with relation to their correlation with the wire-based FFR? And then the second question, what is the correlation with the non-hyperemic indices?
Yeah. So basically, obviously, each of these technologies started from many studies trying to correlate the value to invasive FFR, as it's easily understandable. And obviously those studies were all very good in terms of correlation. There is actually now a blinded comparison between all the available technologies with FFR that showed that the correlation was not one, as it's in almost of the previous studies, or very, very high, 0.95 in terms of area under the curve, but it's a little less. As all the estimation, it's an estimation, it's not a measurement. So I would say that it can be fair to say that is the correlation is around 80 to 85% of the cases if you perform on a daily basis, also in also in complex setting as the ones you would use FFR in. And that's, I think, the main point. So it's a good estimate of FFR. It's not perfect, as all the estimations are. And in terms of correlation with non-invasive, non-hyperemic indexes, we have less data. And it's also tricky because it's comparing two estimations, because actually resting indexes started as an estimation of FFR. Then obviously now we have many data, showing non-inferiority in terms of clinical outcomes. But then it's not so easy, to try to, compare two different estimation of another technology. So I think that the way to go is always to estimate the gold standard, or the thing we started with. So I would be cautious in the interpretation of the data of the estimation of non-hyperemic indexes for the time being, at least.
Would you say that this depends also on the pattern of the disease? That the diffuse disease may not be as reliably assessed by angio-derived methods? Is that something which you think plays also a role when you compare non-hyperemic indices like IFR or RFR with the angio-derived methods?
Yeah, I think this is a fair point. What we are now understanding is that basically the pattern of disease is also something that impact on the discordance between resting and hyperemic indexes. So, for example, if you have a very focal disease, it's more likely to have a positive FFR rather than a positive resting index. And on the other way around, if you have diffuse disease, it's more likely to have a positive resting rather than a positive FFR. And I think that for sure, diffuse diseases, it can be something difficult to be assessed with the angio-derived FFR, because obviously in order to estimate the dimension and the flow across the vessel, you should always start from something that is, I would say, healthy. So if you have a very diffuse disease, it can be difficult for the system to understand which is the real diameter and the real, estimated dimension of the vessel. So you may underestimate some disease in some cases if it's extremely diffuse.
Very good. Now, in terms of clinical evidence, and this is a technology that, has started with investigations, I would say, roughly 10 years ago. And we do have two major randomized trials. Both used QFR as the method of choice in terms of angio-derived methods. The Favor 3 China trial compared QFR guidance with angio alone, and QFR guidance was better than angio alone in terms of clinical outcomes during follow-up. Then Favor 3 Europe showed that QFR guidance actually failed to reach non-inferiority when compared with the FFR-based methods, with the wire-based FFR guidance. So QFR, let's say if this is representative, and that's one of the questions for other technologies, then the angio-derived technologies seem to be better than angio alone, but seem not to meet or to reach the standard of wire-based FFR guidance, which is also established. How do you comment on these two large clinical trials?
Yeah, I agree with your interpretation. What we can say for the time being is that angio-derived FFR is for sure better than angiography. And that's an important point, because most of the procedure in most of the cath labs worldwide are still done based on angiography. So that's something that we should be aware of. And at the same time, we cannot, for the time being, say that it's non-inferior to wire-based. And this is important from two points of view, at least in my mind. The first one is that we are extremely reassured by regarding the safety of the FFR, the using of the FFR in daily clinical practice, because it was associated with extremely low rate of adverse events. And I would say that the other point that we have to acknowledge is that those technologies are still a little bit of operator dependent. And you, for example, in the interpretation of the 3 Europe, you may have a look at the number of positive vessels across different vessels. And while with wire-based physiology is extremely unlikely to have a positive circumflex, for example, in terms of invasive physiology, then within the QFR arm, we add much more positive assessment in non-LAD vessels. And these can be related to the fact that those technologies are still a little bit operator dependent, especially in the estimation of the border across the vessel. So if you change or you think that should modify the analysis, especially at the level of the stenosis, that may impact the value and the positiveness or negativeness of the measurement.
Yeah, so we started out with the promise of these methods to improve overall care by providing physiology findings overall in all the cath labs. And I guess that the Favor 3 China did show a benefit into that direction, that if we put QFR on top of angio alone, we will then win. The second question is, when we compare it with the FFR, with the wire-based FFR, then we seem to fail. And here I would like to ask you a question that seems to be sometimes asked in the community. So when we speak about the FFR, the wire-based methods, we make the assumption that there is a linear relationship between flow and pressure, but we actually measure the pressure. So our assumption is that under hyperemic conditions, there is this one assumption, and that is that there will be linearity of flow and pressure. When we speak about the angio-derived methods, and we'll try to illuminate this a bit, we make many more assumptions, because we essentially do not measure flow, we do not measure pressure. In many systems, we also do not need the aortic pressure measurement either. The only thing we have is manually generated, or sometimes automatically generated, coronary angiography image. And from there, we embark on a large set of assumptions made by computers and mathematicians to give us the output, which is similar to what we are used to, and that is the wire-based FFR. So how do you comment on this, that we actually, by increasing the number of assumptions, may not be as precise as with the FFR? And do you see a problem going in the future with that?
No, I think it's fair. It's an assumption based on angiography, and so basically you have to deal with the fact that many things are not directly measured. I think that what I said before is that you have an overall good correlation. Around 80-85% of the cases, you will end up with a very similar and consistent value. So the idea is when you are not willing to perform invasive physiology because of, for example, in some cases, it's also related to the fact that you want to measure the microcirculation, and in some of the technologies it's not possible, and even if it's possible, it's again an estimation of the IMR. So for example, if you want to perform the analysis, full physiology analysis in the stable setting, I would use the wire, because it's the only way to do it. But then, if, for example, in some other settings where it's highly unlikely that at 3 a.m. in the morning, at the end of the primary PCI, you will end up with FFR or IFR or non-culprit vessel, then we know that basically it could be better than our visual estimation by angiography alone. So my idea is to implement something that can help you in some cases with what you are already doing in the cath lab and performing the best care for the patient. So yes, it's true that you have many assumptions, but as we said, as we have shown by the studies, that it's better than angiography for the time being. It's not non-inferior to FFR. We have many other randomized clinical trials on different platforms that are basically ongoing, and we will have the results in the next year, because we have the Fast 3 on the VFFR, we have the Old Rise with the CutWork system. So we will see, probably in a couple of years, we will have at least 2 other randomized trials, and based on the results of those trials, we may end up with something more conclusive.
I mean, I tend to agree with you, because I think that all we do in medicine is assume. So we are never 100% precise with any of the measurements we do. So if there are more assumptions which a technology is based on, as long as it works in a clinical trial, as long as it's proven in a clinical trial, I think we should probably accept it. And that is why the evidence is so important. So we come to the last part of the conversation, and that is, how can we put the evidence into practice? And you already mentioned one application which seems to be very useful. It promises to be very useful, and those are the non-culprit lesions of ACS patients. As you said, 3 a.m., and we want to have a quick decision for a patient which we just treated for the culprit lesion, and we want to know the significance of the non-culprit disease. In the FIRE trial, which you also headed, there was also a number of patients in whom non-culprit lesions were evaluated with the angio-derived methods. Can you tell us more about what happened to those patients? How did the QFR, I think, in that case, show up? And tell us a bit more afterwards about the AIR-STEMI trial, which is ongoing, which should put this question answer this question in a randomized context.
Yeah, exactly. So what we did in the FIRE trial was to randomize patients with their physiology, complete revasc or culprit-only treatment in older MI patients. So some of the patients received QFR, some of the patients received wire-based physiology, and this was not randomized. So it was based on operator's decision, the availability of the system across different cath labs. So what we did as a sub-study of the trial was to perform a comparison between patients receiving wire-based physiology and angio-derived based physiology. And what we shown is that the overall outcome of the patient was very similar in terms of outcome. And then what we did was to perform QFR in the culprit-only arm. And what we shown is that QFR was actually able to stratify prognosis pretty well in patient in the culprit-only arm, and that was again reassuring in terms of the ability of the technology to be used in STEMI settings. And based on that, what we did is the AIR-STEMI trial, that is a randomized clinical trial including 1,800 patients, in which we randomize patient to either STEMI patient with multivessel disease to either complete revasc based on angiography or complete revasc based on angio-derived FFR. And the arm of using angio-derived FFR received a core lab evaluation of angio-derived FFR with the indication to perform or not to perform PCI, and the suggested plan for PCI guidance based on the pullback. The enrollment was finished some months ago, and we hope to present the results at EAC 2026.
Great. So one of the last questions I want to ask you, we've said that, this is a technology which is very much computer dependent. So basically you have different technologies like QFR, like NGFR, FR angio, you have NewFR. So they all have different systems or algorithms leading to the value in the end that should guide the clinician. My question to you, besides the computer dependency and the program dependency with its various assumptions and mathematical algorithms, is there an operator dependency? Should we know how to use these technologies, and can our use of these technologies impact the values we get which ultimately guide the procedure.
Yes, because each technology, each tool has its own characteristics. For example, if you perform the analysis with mu-FR, so one projection, then you will have to tell the system a proximal normal and a distal normal value. So by moving those points, you will end up with different values. So it's important for you to understand the peculiarity of each technology that are related to the fact that, for example, mu-FR is based on one projection, Catwork system is based on 3 projections. So they are all different, and the interaction with the operator is different across different platforms. All the system are tending to reduce, obviously, the operator dependency or the things that you have to do in order to interact with the system. But for the time being, there is still a little bit of it in each technology. So depending on the fact on the one that you have available in your lab, because it's unlikely to have all of them in all the labs, so you should stick to the one you have and try to understand which is the peculiarity of the system.
Great. I would like to close with the final question, and that was the first question as well. Will these technologies change our practice?
I hope so. I mean, I did the study in order to understand that, so I can't tell you right now, but in my mind, what I would love to do with this technology is, again, to stratify non-culprit lesion and to try to understand whether they can be useful in patients, for example, not receiving a pre-PCI CT in the stable setting. So in settings where you basically are not using physiology right now and you may end up doing it in the next years.
So increasing the use of physiology, this is what angio-derived can help us with in the first place. Thank you very much, Simone. It was a pleasure. Thank you, everybody, for listening, and see you again with the heart-to-heart conversations.